Well, thank you very much. It's an honor to be here. Thank you for the kind invitation. So what I wanted to do is in the next 15 minutes to give you a couple of new concepts, and I will certainly show you some techniques. These are my disclosures. Now, if you think about the traditional treatment of critical limb ischemia, what we've been taught for many years is that we want to establish a single vessel, straight line flow to the foot. And the fundamental principle of that is that when you have a wound or ulcer, you need a blood pressure down there and oxygen content into the affected segment so that the segment does heal. However, if you think about a CLI patient, a lot of these patients are diabetics, and if you look at many of these patients below knee angiography, you have very diffusely diseased small vessels. And sometimes this principle of single vessel below the knee, a straight line flow to the foot, is not enough. Now, how do we determine, who should get complete revascularization versus just limited revascularization of a single vessel? So there are multiple factors you should consider. First, the availability of the target vessel, that what we can actually achieve in the below knee intervention. You want to look at the wound, that how complex is the wound. A tiny ischemic ulcer will most likely heal with a single vessel. However, if you have a complex wound, if you have an amputation stump that's not healing, that's a different patient because it takes time for these wounds to heal. Then you also want to look at your post-PCI angiography and look at the quality of the vessel, because if it's a brittle diabetic patient with a small vessel that you just opened, the likelihood of that vessel staying open is very, very low. Those patients have more than 50% restenosis within a few months. And you need to think about that. And the time frame of what you think, how long it's going to take for the wound to heal. So keep all of these things in mind when you look at these patients. Now, there are multiple techniques, and the retrograde technique is now very popular, so I won't say a lot about that. But I will show you a couple of examples of when retrograde technique does not work, what do you do? And then I will show you some of the examples of how we reconstruct arcuate artery and a transpedal loop, and some of the collateral approaches that you can utilize in a very difficult case to accomplish what you want to accomplish. There are many similarities between the below knee intervention and the coronary CTO, and most of you are interventional cardiologists here, except few. And you are very familiar with the wire techniques and the catheters that we use for coronary CTO, and a similar catheters and the wires can be utilized for below knee intervention as well. But just like you study angiography in a patient with coronary CTO, you also should study the angiography of the below knee vessel when you are taking on a complex below knee total occlusion case to achieve success. Here's an example of a very straightforward below knee retrograde procedure. This is a patient, you can see, that has an antegrade sheath, and the femoral artery is distally occluded, the popliteal artery is occluded, and the reconstitution is at the origin of the anterior tibial artery, and the posterior tibial artery also reconstitutes. In this patient, an antegrade attempt was made at an outside institution, and they were able to get through into the subintimal tract, or whatever you want to call it, through a plaque of the femoral and a popliteal artery, but they could never get into an anterior tibial artery because of the angulation there is between the popliteal artery and the anterior tibial artery. In this situation, a retrograde access can be very helpful. So which is what we did without even trying from above. You can see that after getting a retrograde access, we have just a support catheter, balloon type catheter in the anterior tibial artery, and I was able to use a miracle wire through the occlusion. And this is a poor man's snare, which is a 5 French angle tip glide catheter, and you can just steer the wire into the glide catheter. By that way, you don't have to pull, you just push the wire, and the wire comes out of the other end of the catheter, and you externalize the wire, and now you have an access. This patient then underwent orbital atherectomy of this total occlusion. You can see there's an orbital atherectomy birth, and there's just a lumen through the SFA in a popliteal artery. Then I ended up stenting on this segment using new superior stents, which are now approved for femoral indication. This is the final result. So this is a relatively straightforward retrograde procedure, and most of the time that's all you have to do. Now let's think about a more complex situation. This is a 60-year-old male who has a rest pain of the left foot and had multiple toe ulcers, and he had a prior history of recurrent CLI. He's been actually in 3 times over a period of 2 years with repeated ulcers and below knee disease. So you can see that his femoropopliteal artery is not severely stenosed. It does have some diffuse disease. However, below the knee, his anterior tibial artery is proximally occluded, and the peroneal is the only patent vessel. And then there is a third vessel that you see on your left, and it was thought by another operator that it's a posterior tibial artery, and attempted to push a wire through that vessel, and he was not successful, resulted into a perforation, and then the procedure was stopped and the patient was sent to us. It's important to do foot angiogram in this situation when you want to take on a relatively difficult revascularization. Now, when you look at this patient's foot angiography, you can see that the dorsalis pedis artery very nicely reconstitutes. He has good arcuate artery, in other words called a plantar loop vessel, and he also has reconstitution of the medial and lateral plantar vessel. So there is a good distal target in this patient when you try to put your wire through this difficult CTO. You need a good distal target to be successful. So we did make an attempt to cross this anterior tibial artery from the top. It was not successful. So then we obtained an access into the dorsalis pedis artery, and the retrograde wire also would not cross the total occlusion. When this happens, what you should do is take a balloon and inflate it in the proximal segment into the plane where the proximal wire is. And this is a technique in coronary CTO we call reverse card. This is the same exact thing in the leg. We do a reverse card, and then the retrograde wire will go through that space that you created with a balloon from the top, and then it externalizes, and you can see now that this is the final result after doing a retrograde access. Now you notice in the last angiography in this patient that this patient, we gave this patient an inadequate anticoagulation, and he had a thrombus that embolized from his sheath into the distal portion of the peroneal artery. And the peroneal artery is now distally occluded, which was providing a transverse collateral to the lateral and medial plantar artery. And also there is a small dissection plane in the dorsalis pedis artery from the balloon angioplasty. So the point here is that this is very frequent when you do a below knee revascularization in these small vessels. You will have these type of dissection planes. You will have not a perfect stent-like result. So likelihood of this vessel re-stenosing or re-occluding is pretty high. So in this case, we decided that we will also open up the posterior tibial artery to provide this patient a dual blood supply. So this is a Corsair catheter, which is a septal channel dilator that we use in the coronary CTO, and it works extremely well for this maneuver. Important thing to remember when you do this is that you must have an antegrade access, and I will explain you why. So we have a wire coming down from the anterior tibial artery going through the arcuate artery or the plantar loop vessel, through the lateral plantar vessel in the posterior tip, and now I'm pushing the wire. This is a PTFE coated wire, and now you can see there's a Corsair catheter that follows the loop of the wire, and now we are able to get through the total occlusion of the posterior tibial artery from the retrogradely through the plantar loop, because it would be very difficult to access a lateral plantar artery at the foot level. It's not impossible. It can be done, but this is a much easier way to do this procedure. Now, at this point, you have a couple of different options. Either you can retrogradely inflate the balloon in the posterior tibial artery all the way through the plantar lobe, which is also possible, or you can externalize this wire and inflate the balloon from the top, or you can just try to steer a wire from the top and follow the wire that has crossed the vessel retrogradely. So that was done in this case. Now you can see that we have now ballooned the posterior tibial artery and the wire is in position. Now there is one important caution that I want to tell you. When you do this maneuver and when you are pulling your antegrade wire back, which is the wire that's coming from the anterior tibial artery in this particular case, you don't want to pull that wire through the plantar loop without having your Corsair catheter in position. Otherwise, you may potentially damage that vessel with the wire. So that's the one important thing you have to remember. Patients do experience at time pain when you have a septal dilator and the wire both through the plantar loop. So that's not uncommon. It's usually due to spasm of those vessels. You can give some intraarterial nitroglycerin or give patients some sedation. And after completing the antegrade access, you can see that the posterior tibial artery is now open all the way down. We actually put a drug-eluting stent in the origin of the posterior tibial artery. This is something that we occasionally will do to secure where the ostium of that posterior tibial vessel is. So the next time if this patient has to come back, you can access through the stent, and it gives you a guidance of where this vessel is. Here's another example. You can see this patient also has a rest pain and cellulitis. She's an elderly female. Her femoral popliteal vessels are patent, and this is her below knee anatomy. And this is the kind of case where a good study of below knee angiography is important. You can see the anterior tibial and posterior tibial both are occluded. The peroneal vessel is open, and when you look at the foot in the AP projection, you can't tell really what's actually reconstituting. Either it's a lateral plantar vessel, which is a termination of your posterior tibial vessel, or a dorsalis pedis artery. But when you do an angulated angiography of the foot, now it becomes clear that there is a large transverse collateral vessel going in the lateral plantar artery. So we try to open up the posterior tibial artery in this patient because that was the largest vessel in the foot. From antegrade approach, it was not successful. So in that situation, we attempted the same technique. We went through that transverse collateral from the peroneal artery, and we also have a wire from the top. We inflated a balloon from the wire from the top, and now you can see this is a Corsair catheter and a PTFE wire that's going through this reverse cart that was created from a balloon that was inflated from the top into the posterior tibial artery. And after that, you can see this is a retrograde balloon inflation. This is a ultraverse balloon from Bard, which has a 200 shaft length. So you can actually do this. I think it's very difficult to do this from a contralateral access. Typically, we would do this maneuver from antegrade access. And then now we have one wire from our retrograde position. There is another wire from the top. And this is the final result after doing an atherectomy of some type and balloon angioplasty in this vessel. So in conclusion, you need to carefully understand the angiographic anatomy of the below knee vessel, especially in this complex CLI patients. Consider angiosome, but if possible, do a complete revascularization in many of these patients, especially if they have a complex wounds, because it takes a long time. It's very important to carefully follow these patients. Sometimes we will either do a CT angiogram or do a formal angiography in 3 months on these patients to make sure that these below knee vessels are open, and occasional use of a drug-eluting stents, especially at the site of the starting of the CTO in the proximal segment, is also useful. So I hope I leave you with some thoughts today. Thank you very much.